Now let us talk about how do we resuscitate a patient who has been admitted with lower GI bleeding or hematochezia. So let me take four different scenarios so that we can learn from these cases. Here is an otherwise healthy woman with no comorbid illnesses and on admission, heart rate of 100 per minute, blood pressure 130 by 80 millimeters of mercury, and a good oxygenation. And the hemoglobin comes back as 10 grams per deciliter, and she has not had any more rectal bleeding for the last 6 hours. In this case, like any other management goal, we should set a goal of for fluid resuscitation, keeping the mean arterial pressure goal at 65 to 70 millimeters of mercury. And what about the transfusion goal? So, in this otherwise healthy woman with no comorbid illnesses and stable hemodynamics and and a hemoglobin of 10 grams per deciliter and who has not had any more bleeding for the last 6 hours, it looks like the bleeding has stopped and she probably does not require any transfusion. And if she needs, because of her otherwise good health and no comorbid illnesses, you could set the transfusion goal if the hemoglobin drops to below 7 grams. So let us take another scenario. And before we go that, in this woman, you want to have two wide bore IVs so that if she needs resuscitation, you have everything ready. For now, we just keep her on IV fluids, just crystalloids. So let us look at another scenario. Here is a woman, uh, otherwise healthy, with no comorbid illnesses, but she has lost quite a bit of blood, and as evidenced by her hemodynamics. Her heart rate is 120 beats per minute, blood pressure of 90 by 60 millimeters of mercury, otherwise oxygenating well, and her hemoglobin dropped to 8 grams per deciliter. So, this woman, who is otherwise healthy but had a significant bleed and has ongoing bleed and a hemoglobin of 8, the transfusion goal should be kept at least 9 grams per deciliter because she's actively bleeding and you don't want to wait till it drops to 7 grams per deciliter. And the fluids that you want to give are predominantly crystalloids, and maybe if need be, you can add colloids. Uh, there's not much difference between the two based on some other recent publications, and consider transfusion in somebody who's actively bleeding with unstable hemodynamics. And our goal for resuscitation should be a mean arterial pressure of 65 to 70 millimeters of mercury and watching their mentation, their skin perfusion, and their kidney perfusion by measuring their urine output. So we talked about healthy person, hemodynamically stable, bleed stopped, good hemoglobin, no transfusion. Healthy person, health, no comorbid conditions, severe bleed, transfuse, especially if it's ongoing bleeding. So let us look at another scenario. It's an elderly patient who has a history of ischemic heart disease and a coronary stent. And when you look at the vitals, looks stable with a heart rate of 100 beats per minute, blood pressure of 130 by 80, and good oxygenation. And hemoglobin came back as 8 grams per deciliter. So, in this patient, who is an elderly patient with a significant comorbid illnesses, especially heart disease, these patients are at risk for strokes and MIs if they don't have adequate perfusion. So, these patients should be managed differently, and the transfusion goal in this setting is better to keep it around 9 grams per deciliter, not 7 grams. 7 grams is for somebody who's healthy, otherwise healthy, not having active bleeding, and the bleeding has stopped. Okay. So when it comes to managing their circulatory status, you want to give crystalloids and also packed cells with a goal to keep the mean arterial pressure between 65 to 70 millimeters of mercury. Again, it's not just the blood pressure, but you want to observe their mental status, observe their skin perfusion, whether they have warm hands or cold hands, and observe their kidney perfusion by checking the urine output. Now, the same patient with the ischemic heart coronary artery stent, hemoglobin is 8 grams per deciliter, but in this situation, he is actively bleeding with significant volume loss. And in that case, you want to make sure that you aggressively manage their volume status and also consider transfusion to keep the hemoglobin above 9 grams per deciliter with the use of crystalloids, colloids, and also packed cells. So, in summary, how do I think about resuscitation of a patient with GI bleeding, especially lower GI bleeding or even upper GI bleeding? Is is the patient healthy or has comorbid conditions? If a patient has serious comorbid conditions, I lean towards packed cells to keep the hemoglobin above 9 grams. The next one is I ask myself, is the patient actively bleeding and has significant volume loss or not? If the patient is actively bleeding and has significant volume loss, again, I gravitate towards keeping the hemoglobin above 9 grams. On the other hand, if the patient is healthy with no comorbid conditions and hemodynamically stable, minimal drop in hemoglobin, and in those patients, you could set your goal at 7 grams or above per transfusion. Uh, 7 grams, especially if it drops below 7 grams, consider transfusion. It's also important for every patient with GI bleed to have at least 2 wide bore IV cannulas set in place. And if a patient requires massive transfusion, then you should follow massive transfusion protocol with the inclusion of platelets and prothrombin complex concentrate as part of the massive transfusion protocol. I hope this is helpful. Thank you.